And we're up and away. So thank you again for joining us tonight. Apologies about being a little bit late, but we're here. And we've got Dr. Kapadia with us, who is going to talk to us about acute abdominal pain. It's lovely to have you with us again, Raj. Thank you so much. This is your second session with us. So I know from first-hand experience, it's going to be very informative. So I'll hand over to you and thank you.
Thank you. It's my pleasure. I chose to talk about acute abdominal pain today because it's obviously one of the widest subjects in general surgery, and it's one that we are faced with pretty frequently. I'm mainly going to concentrate on diagnosis rather than treatment, because it's such a broad subject that treatment obviously is more to do with the individual diagnosis rather than a generalized treatment. Now, first of all, I'd like to obviously pay tribute to my teachers in the past who have had to suffer me. Also my peers have put up with me, and obviously my pupils, and in particular my patients, the thousands I have treated over the years. It's unending, really. Right, to start off with, I was faced with this abdomen not that long ago, and it was in fact towards the end of last year, and it was in Australia. I was absolutely staggered when I saw this lady's abdomen. It's not as though she had neglected herself. She had been up to see to the hospital where I was working at this time I think it was virtually every month initially, and then more frequently latterly, for well over 6.5 months. She'd been complaining of increasing abdominal distension, increasing constipation, and then finally diarrhea. When I saw her, it was quite clear that she was obstructed, and just a simple rectal examination revealed that she actually had a tumor of the rectum, and this was the cause of her acute abdomen. I operated on her, and unfortunately, I had to take out virtually all her colon, just simply to be able to close her abdomen. And it was really a salutary lesson in delay. And this is just, I've simply put up to try and say that obviously delay is not the best for treating acute abdomen. Right, well, how big is the problem? 50% of surgical admissions are emergencies, and we know that half of those are acute abdomens. Now, how do we deal with it? Well, acute abdomen should never be equated with an inevitable need for surgery. However, it's important to realize that if you delay something like this in this situation, you can end up with ischemic gut, which will require resection, as opposed to if this individual had an operation earlier, the band that was causing this obstruction could have been divided, and they would not have required a resection of the small bowel. One should always, however, never equate acute abdomen with the inevitable need for surgery. There are plenty of conditions that present as acute abdomen that do not require surgery. And sometimes a wait-and-see policy is good and necessary. What is it most important, though, is that we must reach a diagnosis, and we should reach a diagnosis as early as possible, as this prevents delay in effect. Right. So what are the causes of abdominal pain? By far, the major cause of acute abdominal pain is non-specific abdominal pain, and I'll list them shortly. Otherwise, they're the usual culprits: acute appendicitis, gallstone disease, intestinal obstruction, now increasingly diverticular disease, pancreatitis, all these which initially don't necessarily need surgical intervention. Similarly, with abdominal malignancy. There are occasions, however, when one may well need urgent surgical intervention, as one does with, not infrequently, with abdominal trauma or with a perforated viscus. Okay, what are the causes? We'll look at, first of all, the causes of non-specific abdominal pain. Well, a lot of these are infective, be they viral, bacterial, or parasitic. Then there's obviously causes not directly related to general surgery, as in gynecological causes or urological causes for that matter. There is today. Then there's what's called pain not actually related to the intra-abdominal contents, but to the abdominal wall itself. And there you have nerve injuries, herniae, myofascial pains, rib tip pains, nerve root pains, and even rectus sheath hematomas. One mustn't, increasingly, we are seeing psychosomatic abdominal pain. More often than not, I think this is best, it's best to come to this diagnosis by exclusion rather than primarily. Right. With the acute abdomen, it's important that we get a correct diagnosis. And to get to this, one needs to deduce it from the observed facts rather than to jump to a conclusion rather. And it is important to diagnose it early because we can initiate treatment. The other thing I'd like to mention is it is important that the patient be given pain relief early. It's used to be commonly taught in medical schools that most analgesics will alter the pain and so confound diagnosis. This is no longer held to be true. And I can vouch for that. It is very important that the patient be comfortable. They're more likely to give you a coherent history if they are comfortable. As a general rule, it's important to remember that severe abdominal pain that's lasted more than 6 hours is likely to be caused by a surgical condition rather than a medical condition. The relationship of vomiting to pain, its frequency, character, and also is also important to take into account, as is loss of appetite. So the diagnosis does depend very much on the history that we can obtain, and also for thorough physical examination. And when examining a patient with abdominal pain, it's important that one applies anatomy and thinks anatomically as to why the individual is getting the abdominal pain. In order to do this, it's important to know what the nerve supplies are. We mustn't forget that the nerve supply to the abdomen comes from the lower 6 thoracic nerves, and as well as the 12th nerve. There is some innervation to the very lower part of the abdomen from the iliohypogastric and ilioinguinal nerve. Below that, all the nerves will be supplying the lower limbs rather than the abdomen. I put the next slide up to really, this slide is very diagrammatic, and really is meant to remind one that we look at one has to consider the anatomical force of the nerve, as well as its distribution, and to remember the segmental nerves. Now, pain can be referred, obviously, to where the innervation is coming from. Hence, with a perforated duodenal ulcer, pain will be referred to the shoulder. Biliary colic will be referred to the right shoulder tip, or rather tip of the right scapula, rather. Acute pancreatitis and renal colic is often lumbar, and uterine pain and rectal pain is often sacral. Now, phrenic nerve gets irritated if there's irritation of the diaphragm, and that can occur from anything that's intradiaphragmatic. Then the pain distribution obviously is in the neck and on the shoulder. Hence, abscesses in particular between the diaphragm and the liver, or between the diaphragm and the spleen, perforations of the stomach or duodenum will all cause diaphragmatic irritation and pain. When looking from the back forward, one should always remember that the first solid organ one comes across are the kidneys. After the kidneys, there's the pancreas, spleen, then the liver, and finally the stomach and the duodenum goes retroperitoneal. So disease of the duodenum in particular will be referred to the back. Now, where is the pain from the viscera? Well, from the upper viscera, pain tends to be referred in the midline and is hypogastric. Pain from the mid-gut goes to the middle of the abdomen and the periumbilical region, and pain from the hindgut tends to go to the suprapubic region. Now, the character of visceral pain is due to stretching of the gut, distension, and contraction against resistance. Now, stretching will occur against adhesions. Distension will occur quite often with obstructions, and contraction will occur against resistance will occur again where there's an obstruction, or as in biliary colic, where the pain you get pain from the gallbladder because of contraction against a stone in the gallbladder neck. One needs to consider the history of the present condition, and at all times we need to consider the age of the patient, the type of time of onset, the mode of onset, and the acuteness of the pain. It's important to consider the function of the bowel. It's also important not not to forget in women in particular, pain in relation to the menstrual cycle. When examining a patient, one needs to look, palpate, and observe for tenderness and rigidity. Rebound, I don't think is a particularly good sign, and it just causes pain without necessarily giving you much information. It is particularly important when examining the abdomen to feel for masses. Percussion is useful. Percussing for liver dullness in particular can be quite elucidating. Examination for free fluid. And finally, don't forget the rectal or vaginal examination, and if possible, to examine with a hand on the lower abdomen so that you get a bimanual examination to feel any pelvic structures. It's important to know the general attitude of the patient, as well as the general parameters such as blood pressure, pulse, and the patient's temperature. I've lost myself there. Okay. Now, shock is obviously one extreme of the presentation of an acute abdomen. It occurs early in hemorrhagic situations that will occur with the rupture of an aortic aneurysm or rupture of a sphenic aneurysm. It tends to occur much later in patients who have third space sequestration, particularly if there's obstruction. It tends to be late if there's bleeding into an infarcted bowel. And it can occur even later if there's continuous vomiting and or diarrhea. But it's certainly something to look at and to try and observe in patients who present acutely and who one hasn't seen before. In these, one will get general changes as well in the parameters of heart rate, blood pressure, respiration, respiratory rate, etc. Right. What is also important to exclude in people with abdominal pain is medical causes. Cardiac derangements can cause abdominal pain, as can inferior myocardial infarction can present with epigastric pain. Renal diseases can again present as abdominal pain, as can cirrhosis. Tuberculosis is not such an important thing these days. One really rarely sees it, and certainly I have never seen it in Australia. I have seen it on a few occasions in Britain, but again, it's becoming increasingly rare, even there. The other thing one needs to consider is the medication the patient's on. It's important to remember that steroids will diminish the symptoms of inflammation. With it, patients on steroids are also more prone to ulceration. They're more prone to, and consequently, bleeding as well. They're much more prone to bowel perforations. It's particularly important to remember the effects of antibiotics and how they can mitigate the symptoms of intra-abdominal disease. Right. It's important, as I said, to consider where the initial pain starts. The initial pain of appendicitis usually starts in the epigastrium, and it moves into the either into the suprapubic region or into the right iliac fossa. Similarly, obstruction of the colon will tend to start off in the lower part of the abdomen, but will, as the obstruction develops, will tend to move more generally. Acute abdominal pain without symptoms. Well, think of acute appendicitis in its earlier stages, acute obstruction of the gut, especially the small bowel, simple intestinal colic, acute pancreatitis. The acute pancreatitis often will present with not just central and epigastric pain, but also back pain. And so putting the two together will help with to allow one to come to that diagnosis. Obviously, one needs to look to exclude, as I mentioned before, coronaries and also nerve pain. In shock, you'll get severe abdominal pain and collapse, as well as general rigidity when the patient, this is an acute emergency, obviously, and the patient, these patients, common cause of this would be perforated ulcers, more rarely other gut perforations, such as the perforated diverticularly. But again, you'll see it with dissecting aneurysms. Here, one looks for absence of liver dullness, tenderness rectally, which suggests inflammation of the peritoneum. But it is also important, especially if they have more pain in the upper part of the abdomen, you can get that with pleurisy. Moving on to tenderness in the right hypochondrium. This tends to be mainly associated with acute appendicitis. Acute cholecystitis. You can see it occasionally with high appendix or with pleurisy, and we rarely see it these days. But a leaking duodenal ulcer could also give you pain in the right hypochondrium. And the reason for this is that it's bounded in the right hypochondrium, usually by adhesions, and that's why the peritonitis is localized. Right. Moving on. Tenderness and rigidity in the left upper quadrant is usually caused these days by pancreatitis. You can occasionally get it in a perforated gastric ulcer or subphrenic abscess, so these are pretty uncommon. We're seeing much more jejunal diverticulitis now, and this certainly does present with pain in this area. This diagnosis is really only made on CT scan. Occasionally, you can see it in post-trauma in a ruptured spleen that it's been has a lot of adhesions on the left iliac fossa, and so the bleeding is confined. And similarly, you get this with sort of leaking of an aneurysm of the splenic artery. Tenderness in the right iliac fossa these days is almost invariably due to appendicitis, and that's got to be the first thought. You can occasionally get it if you've had a chronic leaking duodenal ulcer. Similarly, pancreatitis, because of a leak of the pancreatic enzymes down the right paracolic gutter, can present as pain in the right iliac fossa. There are other less common causes of inflammation in this area, like mesenteric adenitis, inflamed Meckel's diverticulums. You can occasionally see it in acute cholecystitis, though I must admit, usually in these, unless you can feel the liver and know that the gallbladder is actually lying low, you'll get pain in all along the right side. Left iliac fossa pain these days is almost invariably due to diverticulitis. Occasionally, you can get it in inflammation around the cancer of the colon. That is pretty uncommon, I must admit. Diverticulitis is, by and large, the virtually only cause that one comes across. Occasionally, you'll find you get a lot of left iliac fossa tenderness with a mass and a palpable, painful mass. And again, this is will almost certainly be around diverticulitis. Right, moving on. And that's about the main presentations. Well, what investigations should you do? Well, obviously a full blood count. If there's inflammation, you should see elevations in the white cell count. You may see an elevation in the platelet count. And if you can get a differential, invariably it will be neutrophils that are raised. It's important to get urea electrolytes, as you will get derangements of the urea of the electrolytes, especially with diarrhea or severe vomiting. Similarly, a lipase is absolutely paramount these days because of the frequency with which one sees acute pancreatitis. And the amylase is absolutely diagnostic of this. Clotting is getting to be increasingly more essential, shall we say, investigation, because people are living longer. We're seeing many, many more people on anticoagulants, antiplatelet agents. So bleeding is becoming increasingly common, especially in these patients. And so clotting is particularly useful to get. And finally, radiological investigations. I must reiterate that I think it is most important that you have some diagnosis in mind before you order radiological investigations. These days, we don't often use plain abdominal X-rays. They've gone out of favor because of the ease with which we can get CT scans, and now most ED departments have ready access to CT radiology, and that would be the investigator of choice. There are certain things, however, that I think, certain situations I think where probably radiological investigations are essentially unnecessary. A patient who presents with right iliac fossa pain with rebound tenderness and cough tenderness, and clearly who has right iliac fossa peritonitis has got to have appendicitis unless proven otherwise. And I'm not sure that a CT scan showing that they've got acute appendicitis really adds anything to the diagnosis. And personally, I would like to see fewer scans of appendices done, however they are. Ultrasound has become, is probably the first investigation that one should think about, because it's non-invasive. It's should be readily available. Unfortunately, in a lot of places, it's only really available, certainly through an X-ray department during the working hours, which is a shame. But more and more ED practitioners are able to do bedside ultrasound. I think they provide a lot of very useful information. So the two investigations I tend to rely most on would be ultrasound and CT scans. Increasingly, I'm finding I'm using the MRIs, but that tends to be mainly for people with more chronic abdominal pains, especially when the pain is obviously not colonic and not upper gastrointestinal. In that situation, MR is particularly useful, especially to look at the small bowel. Other investigations after radiology would be peritoneal investigations, and then these days, peritoneal lavage has gone completely out of favor, and it's probably just as easy to laparoscope a patient. And the final investigation should really be a laparoscopy if you can't come to a diagnosis and so able to treat. I think with the vast numbers of diagnoses one can have of diseases in the abdomen, one needs to get to a diagnosis, and having got a diagnosis, then initiate treatment, be it by surgical means or by conservative treatment. As I say, in a large number of conditions which are common, like pelvic inflammatory disease or diverticular disease, treatment would be initially with antibiotics and resuscitation with fluids, and only if and observation of the patient, and only if they don't respond would you consider going on to offer surgery. Right. Well, that's my rundown of acute abdominal pain. So we move on. Thank you for listening. I'd now really like to throw it open for questions. So
just wanted to ask you.
Yeah, sorry. Yeah, go on.
I just wanted to ask you whether you use intravenous IV antibiotics for acute appendicitis instead of operating.
It depends, shall we say. By and large, operation is still the way to go, and the evidence is that a lot of appendicitis will respond to IV antibiotics. However, there's still a 30% will become symptomatic again within a year. So it depends very much, to go back to what I started with. And it will depend on the age of the patient. In children, I tend to favor surgery rather than antibiotics. They usually don't take to having repeated antibiotics as well. They don't like being confined to beds. On the other hand, with an older patient, yes, I'm especially one with a lot of comorbidities, I'm more inclined to try IV antibiotics. Does that answer your question?
Yes, I guess you're saying that it's not the first line treatment.
Not yet. No, not at all.
Mm. Okay. Only for more frail patients, maybe patients who are not a surgical candidate.
Correct. They're I mean, you know, surgery in them is obviously much more risky, and then I think it's weighing the risk. Intravenous antibiotics is worth it, worth a try.
Mm.
And we
Yeah,
use it,
but-
we use it enough in diverticulitis. So the appendix is after all, is just another diverticulum.
Mm. Yeah.
Being facetious, but I mean, it is true though.
The other question is, do you use ultrasound much for diagnosis of abdominal pain in children?
We're using it more and more, I have to admit, but I it it depends. I mean, unfortunately, with ultrasound, it's very much operator dependent. I don't personally perform ultrasounds, but I mean, it very much depends on who performs the ultrasound. I worked with a radiologist when I was in Britain, who was very good at imaging the biliary tree, for example. And so all my gallbladders had their biliary trees ultrasounded by him, and he could tell me if they had even a stone as small as 5 millimeters in their duct. While there were others who couldn't do that, but I could rely on that to shorten the surgery by not having to do preoperative ventral, for example. So, well, I guess what I'm trying to say is, if you trust the person doing the ultrasound, yes, I think there's no harm at all in using ultrasound as a diagnostic tool.
And with patients with gallstones found, say, incidentally on say, you know, they were having a ultrasound or CT for something else.
Yeah.
Would you want us to refer them to a surgeon, even if they haven't had any symptoms?
If they've had no symptoms, there is no reason why they need to have anything done about their gallstones, in all honesty. And I really think only symptomatic gallstones should be removed. After all, there are risks with any operation, and I'm not sure it is necessarily wise to do that. One mustn't forget that 30% of people with gallstones never ever know that they've got them.
Mm.
I mean, at least that's the figure we were always quoted, and I'm willing to believe it. I mean, in Britain, where there's still a lot of post-mortems done, a huge number of gallstones turn up, or that have not had any, and the patients have not had any symptoms.
Mm. Mm. Mm.
And I say the quoted figure is 30% don't never come to surgery.
Yeah.
The trouble is, the minute you tell somebody they've got gallstone, they get they get symptoms.
Yeah, yeah,
If you know what I mean.
yeah.
How real they are, who knows? But I mean, once somebody starts complaining about biliary symptoms, I think you do have to see them and treat them.
Mm. Mm-hmm. And do you ever use a HIDA scan, like
Yes, I
after
do.
Okay, when do you use it?
I tend to use it in people who I think have got biliary dyskinesia, and people with no stones, where the symptoms are absolutely classic of biliary disease. I'll use a HIDA scan then,
Mm-hmm.
and if it's abnormal, I'll take their gallbladders. I've done that for all my surgical life. I mean, I started using them, a HIDA scan, in the late 80s, late 1980s, and I've never had cause to regret it, in all honesty.
Yep, yep. All right, well, that's all the questions I have. But thank you very much.
Pleasure, pleasure.
Thank you, Stephen, and thanks, Raj.
Pleasure.
I probably have questions, but they're not really at the level that they need to be, so I might ask them to you later.
Okay, whenever.
All right. Well, look, I think we might have an early night tonight, and thank you again. You've had a big day, and we really appreciate you taking the time to do a session for us. And thank you, Stephen, for joining us, and Richard, if you can hear us. It's lovely to have you both join us. I know you often sit in on our sessions, and it's really appreciated. Your support's very appreciated. So feel free to let me know if there's any topics you really would like us to try and find someone to present on. So, all right, gentlemen.
Thank you very much.
Thank you. Have a lovely
Pleasure.
night. Good
Okay.
night. Bye-bye.
All right.